تمام. Okay, let me just share my screen. Can you see the screen?
That's clear.
تمام. Okay. So first of all, Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Tasneem Al-Ibrahim. I'm a fourth year medical student, and today we're going to be solving some renal pathology questions, inshallah. I really hope that this is helpful for you guys. I've collected questions from multiple resources, including UWorld, AMBOSS, Robbins Pathology, and Time Pathology Q&A. Okay. So if I speak too quickly, feel free to stop me. And if there's one point that you don't understand or something, again, please feel free to stop me anytime. So, let me just get a pen. So, okay, let's do the first question. So, a 40-year-old man comes to the physician because of a 2-week history of fatigue, lower extremity edema, and dark urine. He has no history of serious illnesses and he takes no medications. He does not use tobacco, alcohol, or drugs. And his blood pressure is 132 over 83 millimeter mercury, and his pulse is 83 per minute. Sorry, 84. Physical examination shows symmetric pitting edema of lower extremities, and laboratory values show a serum creatinine level of 1.1 milligrams per deciliter. Urine analysis shows 4+ proteinuria and microhematuria, and electron microscopy of the specimen obtained from the kidney biopsy shows dense deposits within glomerular basement membrane. Immunofluorescence microscopy is positive for C3, not immunoglobulins. Which of the following is the most likely pathological mechanism that explains this patient's condition? So first, you guys just read this and answer it in the chat, basically, and then we're going to go over the answer. So I'll wait for you to put in your answer. I'll highlight some parts for you just to make it a little bit easier. Okay, B is a good answer, but check here. Wait, let me highlight some other parts for you. So first of all, he has lower extremity edema, right? And he has proteinuria plus microhematuria, both. So what is this giving you? What kind of disorder do you think this patient has? And then it's also telling you there are deposits within the glomerular basement membrane with C3. Excellent, C. So, okay, that first of all, this patient, he has 4+ proteinuria and microhematuria. And before we get to the labs, let's go to the history. He has lower extremity edema. No history of serious illness. This is relevant, and we'll look at that in a minute. And no medications, also relevant, and we'll look at that in a minute. Come on, any drugs. His blood pressure is high. تمام? This is also pretty important. And then again, symmetric pitting edema just solidifies the kind of edema we think he has, because if it's not pitting edema, it's non-pitting, you think of like thyroid disorders and so on. That's called mixed edema. تمام. His creatinine level is high. And again, we said proteinuria and hematuria. So what does this patient have? What do you call this disorder? Of hypertension and hematuria, and he also has proteinuria. Nephrotic and nephritic. Okay, when you have hematuria, it's no longer just nephrotic, it's also nephritic. Because remember, what is nephritic syndrome? It's with blood pressure being high and hematuria, right? And some proteinuria. So this patient has high blood pressure. So that's first tick. Second tick is the microhematuria. And then you see the proteinuria, and this should give you a little bit of a clue. Right? What is a disorder that goes from one to the other? Remember, you can't start with nephrotic and then go nephritic. Usually you start with nephritic and then you go nephrotic, right? That's when the basement membrane is not working so well anymore, and now the protein is coming out. So what are we dealing with here? What's coming to your mind when I tell you this went from nephritic to nephrotic? Most likely, I mean, judging from the patient's history. IgA is a good guess, right? But let's keep reading further. Here it says shows dense deposits within the glomerular basement membrane, and it's positive for C3, not immunoglobulins. So IgA is now excluded, right? Because it's an immunoglobulin. And C3 here tells you not post-strep, no, and not anti-GBM. Anti-GBM will give you antibodies against GBM, right? And it will give you a different picture. The answer is C, persistent activation of the alternate complement pathway. Specifically, this is MPGN, proliferative glomerulonephritis, okay? And MPGN, if you guys remember, it's divided into types 1 and type 2, right? And type 1, what does it have? It has IgG and C3. Type 2 does not have IgG, as you can see here, no immunoglobulins, only C3. So this is type 2 MPGN. And MPGN can be classified under both nephritic and nephrotic syndrome. Typically, it starts with nephritic, and then it goes into nephrotic. Tamam? And Danny, just to explain what persistent activation of the alternate complement pathway means, it basically means that we have C3 convertase, which is part of the complement pathway. And this has antibodies against it. So what this causes is that it keeps being activated, the C3 convertase. And so now you have things against C3, and it's depositing in the glomerular basement membrane, and it's ruining our kidney, right? And when it happens for a long time, it can eventually ruin it so much that it turns from a nephritic picture to a nephrotic picture. تمام. You guys, one of the things you said was post-strep, but you can see here, he has no history of serious illness. تمام? And so that kind of rules it out for you. Usually they will tell you, oh, well, 4 weeks ago, this patient had a flu or something, and he was coughing, and now he has XYZ, you know? That would make you suspicious for post-strep. And for antiglobular basement membrane, it would give you a different picture. He would also have something in his lungs, right? Because the basement membrane is in different places in the body, right? And so the patient can have respiratory issues, for example. But here he does not have any of this, right? The only thing he has is in his kidneys. Does this make sense to you guys? Amazing. Okay. Okay, tamam. Let's go to the next question. You have an 11-year-old girl coming to the physician with her mother because of a 2-day history of passing cola-colored urine. During the past week, her mother noticed episodes of facial swelling, and the patient had a rash on her face about 4 weeks ago. A renal biopsy after immunofluorescence is shown right here. Which of the following is the most likely diagnosis? Excellent. It is A. Tamam. So, the cola-colored urine is a sellout, right? So it tells you right away if you guys watch Sketchy Yani. But usually this is how they will describe the color of the urine, especially after post-streptococcal or post-infectious glomerulonephritis. And then this rash on her face is a really interesting thing that you can keep in mind because one of the things that is caused by streptococcus is scarlet fever. And scarlet fever can give you this picture here. So you can see that there's rash on the cheeks and on the rest of the body and the strawberry tongue. And on immunofluorescence, you can see that there are immune deposits everywhere. And what are these? You guys know what these are? These are, one second. The circulating immune complexes are from post-streptococcal glomerulonephritis. Excellent, mashallah. Tamam. Okay, next question. And also, by the way, when you're solving these questions, especially renal, yani, and anything related to cancers as well, pay attention to the age, because the age tells you a lot. And this question, the one about post-streptococcal, okay, didn't really tell you much, but generally try to pay attention to that because it does give you a nice differential. Right, next question. A 62-year-old white man comes to the physician because of a 10-day history of fatigue and lower leg swelling. Over the past 6 months, he has had a 3.6 kilogram weight loss. He has chronic bronchitis and he uses an albuterol inhaler as needed. He has smoked 1 pack of cigarettes daily for 44 years and drinks 1 alcoholic beverage daily. His temperature is 37 degrees Celsius and his pulse is 88 per minute and his blood pressure is 120/75. So his vitals are normal. He appears thin. Examination shows 2+ pretibial edema bilaterally, and cardiopulmonary examination shows no abnormalities. The laboratory studies are right here. And then X-ray shows a right upper lobe density. And then a CT scan also shows a right upper lobe mass. Which of the following is the most likely diagnosis? This one is a little bit tricky because of the long history, but it should be straightforward. First of all, figure out what disorder the patient has, and then go from there. Look at the labs right here. This one should tell you what kind of disorder the patient has. So can you guys guess what he has? You're saying E. Okay, it's not E. E would give you a slightly different picture. Like, should we discuss the answer? Okay, okay. Take your time. This one, to give you a little hint, you're saying D. Okay, nice guess, but the picture would be slightly different. It's true that this patient has something wrong with his lung, um, and it's a really smart guess, but it's not the kind of picture that it gives you usually. Also, the labs would be different a little bit. No, G wouldn't give you respiratory symptoms, by the way. Okay, you want me to say the answer? So the answer is E, membranous nephropathy. I know this was tricky, and I doubt the exam would be that difficult, to be honest. It would be more straightforward. But the reason why I bought this is because of the causes that lead to these disorders, right? So if you look at the tables or the slides, sorry, that the doctor gave you, focal segmental glomerulosclerosis has its own causes, membranous nephropathy has its own causes, MPGN, and so on. They all have their own causes, right? Oh, you chose E? Wait. Oh yeah. I don't I don't know why I thought you chose F. Okay. No, that's weird. Okay. حقك علي or حقك علي. I'm not sure who you are بس يعني ما شاء الله. تمام. Okay. You're right. It is membranous nephropathy. تمام. The reason why, first of all, okay, as a rule, okay, the most common in children is minimal change disease. The most common in adults is membranous nephropathy, and the most common in everybody and generally is IgA nephropathy. تمام. But membranous nephropathy has things that can trigger it, and one of those things is to have a malignancy. And so in this case, the malignancy in this patient is probably lung cancer, judging by his smoking history and weight loss and the CT findings. So the first thing you would do is to figure out, okay, is this a nephritic or nephrotic syndrome? Okay, and now we look here, focal segmental glomerulosclerosis, nephrotic. Okay, IgA nephropathy usually presents with a nephritic picture, so I'm going to remove it. MPGN usually starts with nephritic, and they're not saying anything about C3 convertase or IgG. The typical picture isn't there, so we'll remove this one. Granulomatosis with polyangiitis usually they're going to tell you, for example, C ANCA is high, right? They're going to tell you, oh, this patient is coughing, or he's short of breath and wheezing. And this picture is very similar. It's not the answer here. RPGN, or rapidly progressive glomerulonephritis, my goodness, would also give you a slightly different picture. The creatinine would be really high, and usually it's post-streptococcal glomerulonephritis, but it's not the case here. Thin membrane disease, they don't have respiratory symptoms, and it's pretty rare. And so the answer, your choices now are focal segmental glomerulosclerosis and membranous nephropathy. Focal segmental glomerulosclerosis has its own risk factors, like for example, HIV, and that's not present in this patient. So you go to, and also you go to the most common. Whenever you look at something, you first think of the most common thing, and then you think about what other things it could be. And you think about, okay, does the patient have a risk factor for these other things? In this case, the patient doesn't have it. And to be honest, it's not an easy question, but yeah, does this make sense? Okay. Okay, tamam. You guys are doing great, by the way, Amjad. Tamam, okay. Next question. A 24-year-old previously healthy man comes to his physician because of dyspnea and hemoptysis for the past week. Now, this is your question. Examination shows inspiratory crackles at both lung bases, and the remainder of the examination shows no abnormalities. His hemoglobin, okay, perfect. His hemoglobin concentration is 14.2. So just the highlights here really are that he has high protein, right? And hematuria. See, the protein isn't that high. It's not into a nephrotic picture. And he also has pulmonary infiltrates and respiratory symptoms. So this is, as you said, B, anti-glomerular basement membrane. So this is how it will come. And when you, especially for this exam, tamam, and for literally all third-year exams, besides maybe GI and MSI, I'm gonna exclude, you are solving questions, and then when you solve more questions, you find patterns. And the pattern for anti-GBM is, oh, well, he has dyspnea and he has, sometimes they have a productive cough like hemoptysis here. And hematuria with some proteinuria, so a nephrotic picture, this is anti-GBM. Tamam? This is how it usually comes, yani. Okay, let's go to the next question. A 6-year-old girl is brought to the physician because of increasing swelling around her eyes for the past 3 days. So now you already have a differential. What could this patient have that is causing edema, periorbital edema? Her vital signs are within normal limits. And yes, physical exam, again, same thing with shifting dullness. So she has anisarca, so generalized edema in her body. And her serum albumin is high. And her cholesterol is high, and she has 4+ proteinuria and fatty casts. So what does she have? A nephrotic picture. And what do most children have with nephrotic syndrome? What is the most common cause? As you said, no, wait a second, it's not E. Sorry, let me remove that. It's not E, but you said E, but tell me why it's not E. Why is E wrong? Exactly, light microscopy. So light microscopy, first of all, this might be recorded, so let's say it out loud. She has minimal change disease, as you said. Minimal change disease looks perfectly normal on light microscopy, but it looks abnormal on electron microscopy. This is when, as you said, there would be effacement of the foot processes of the podocytes. Yes, so F. So on light microscopy, it's normal, but if we do electron microscopy, it's abnormal. And this isn't relevant to your exam right now, but usually we don't do a biopsy in children because we just assume that, yeah, they have minimal change disease. But if we give them steroids and they don't respond, or we're not sure of the diagnosis, then we can do a biopsy. But generally, you do not, the only population that you don't do a biopsy on are children. Come on, you guys are amazing. Like, next question. This time we have a 70-year-old woman. She's coming because of a 4-month history of fatigue and worsening swelling of her ankles and a 5-kilogram weight gain. Neurologic examination shows diminished 2-point discrimination in her fingers, and she has a hemoglobin A1C concentration of 9.2% and a creatinine concentration of 1.3 milligrams per deciliter, and she has heavy proteinuria on her urine analysis. What would you find in her biopsy? Excellent, yes. So indeed, it's nodular glomerulosclerosis. And just to tie everything together, to go back here, which of these do you think would the patient have? A diabetic patient who has a glomerulopathy. Exactly, it's non-immunologic. There's no antibodies mediating this. It's her diabetes that is causing all of this. It basically ruins your entire body. And one of the first things it ruins are actually the kidneys because of how tiny the blood vessels are. So yes, exactly. Come on. Okay, next we have a 55-year-old woman coming because of an annual physical examination. She has no new complaints except fatigue. She has an 8-year history of chronic low back pain and severe degenerative joint disease that has been documented on MRI. And she has an anterior wall myocardial infarction 4 years ago. Her current medications are naproxen, acetaminophen, oxycodone, aspirin, atenolol, and simvastatin. And her blood pressure is high, 130/80, and her pulse is 72. Laboratory studies are shown here. Make sure you observe them well. And she does not have monoclonal gammopathy. And 2 years ago, her BUN is 22. Her creatinine was 1.6. Like, so her creatinine increased and her BUN also increased. Tamam? And look at this. There's a very important thing. She has a very, very long history. But a component of these is very important for you right now. Okay. Should I show the answer? Okay. So the answer is, as you said, C. The component that was really important for you is her medication history. She's taking naproxen, and she's taking oxycodone and aspirin and atenolol. She's taking all of these medications that all can hit her kidney, basically, and cause tubulointerstitial nephritis. And you can see here that her serum creatinine has increased and her BUN has also increased. So you can do the BUN creatinine ratio, basically. But the most important thing here really is the medications. And usually what causes tubulointerstitial nephritis are NSAIDs. But you also have other kinds of drugs like diuretics that can cause it. Is this clear? Come on. Great. Alhamdulillah. طيب. The next question. A 17-year-old boy is involved in a motor vehicle accident in which he sustains severe blunt trauma to the extremities and abdomen, and over the next 3 days, he develops oliguria and dark brown urine. The urine dipstick is positive for myoglobin and for blood, but microscopic examination of the urine shows no red blood cells. His serum urea nitrogen level increases to 38 grams per deciliter, and he undergoes hemodialysis for 3 weeks. And his condition improves, but the urine output remains greater than 3 liters per day for a week before the urea nitrogen returns to normal. Which of the following renal lesions was most likely present in the patient? Excellent. Yes, it is B, acute tubular injury. So what happened in this patient is that he basically he underwent trauma and he lost blood, and one of the organs that lost blood in his body or was not well perfused is the kidney. But the most important thing that happened to this guy is that he had myoglobin. And myoglobin, what is it considered for the kidney? It's considered toxic. Tamam? And so what kind of pattern would it give you in terms of the damage that happens? Is it patchy or is it continuous? Continuous, excellent. So when we talk about patchy necrosis, it's usually because of, or patchy acute tubular injury, it's because of ischemia, right? And you can think about it that your kidney looks like this, and it's being perfused with blood. So when you decrease the blood that's going there, I mean, you're not completely cutting it off, you're just decreasing it. Some parts will get better blood supply than others, right? So you can expect it to be patchy. But if you have something toxic in the tubules, then they will all get impacted and you will have a continuous pattern of injury. Tamam? Now, another thing I want you to notice here is that this patient had acute kidney injury, and acute kidney injury comes in stages. And so he developed the first stage, which was oliguria, right? It starts with nothing comes out because the kidney is not working anymore, so it's not able to make urine. But once it starts to recover, it starts to have polyuria. You start to have increased urine output. Now here he had more than 3 liters per day, and then he finally went back to normal. So I want you just to keep this point in mind because you might be asked about it. Especially, I think, more in clinical lectures, but it's good to keep in mind. Okay, does this make sense? Should we move on? Alhamdulillah, tamam. Okay, so you have a 3,000 gram, 6 pound, 10, okay, whatever, male newborn, delivered at 38 weeks of gestation, and he develops respiratory distress shortly after birth. Physical examination shows low set ears, retrognathia, and a flattened nose with club feet. And then within a few hours, unfortunately, the newborn dies. Examination of the liver at autopsy shows periportal fibrosis and dilatation of the peripheral intrahepatic ducts. What is the patient's condition associated with? So here the age is very important, as well as the autopsy. A is a good guess, but it does not explain the autopsy findings. B is a great guess as well, but it does not happen at this age. D would explain the physical findings, but it would not explain the autopsy findings at all. Let me highlight this for you. He has dilatation of his hepatic ducts, and he's a tiny little baby with respiratory distress shortly after birth. E, excellent. Okay, what happened to this baby? This baby has a chromosomal mutation on chromosome 6, not 16. What is 16? What is a mutation on chromosome 16? Okay, let's say, what does the baby have first of all? The baby has polycystic kidney disease, but recessive. تمام? Let's do a quick recall. We have something called polycystic kidney disease. Polycystic kidney disease is when you have a kidney, but it has a lot of cysts on it. تمام? When you have a recessive form, the cysts are tiny and small in all the collecting ducts. تمام? And usually happens in newborns, in little kids. And because both of their kidneys are having all of these cysts and they're not working very well, the kidneys don't do their job in when in utero, and when they come out with something called Potter sequence, which is basically oligohydramnios. Okay, and so as you see here, low set ears, retrognathia, flattened nose, club feet, respiratory distress. He can't breathe. That's why he dies, because his kidneys aren't doing their job, and he has an overload of fluid in his body. Tamam? And so if you look at the kidneys, they will be pretty smooth, but if you look at them, they'll have these tiny little cysts everywhere. تمام? And again, this is chromosome 6. Now, this polycystic kidney disease, the thing about it is that it's not only, it's called polycystic kidney disease because the major thing it impacts are the kidneys. But actually, there are cysts everywhere else in the body as well. Well, not everywhere else, mostly the liver. And also in adults, where do you have them? Where do you have balloons? And let's not call them cysts, let's call them balloons. Where would you have balloons in adults with dominant form of polycystic kidney disease? So you would have them, for example, as berry aneurysms in the brain or mitral valve defects, right? So in here, what they told you is baby. This is the first clue. Second clue, oligohydramnios, tamam, and the Potter sequence that you can see here. And the third clue is he has cysts in his liver, right? And so these three things tell you, okay, this is polycystic kidney disease, recessive form. Bilateral hypoplasia of the kidneys, the first answer that you guys said, is correct if you remove the autopsy findings. Then yeah, okay, it could be possible that the patient's kidneys didn't work and they caused oligohydramnios with low set ears and retrognathia and so on and so forth, right? And then you also said D. D gives you the same look here, تمام? But it's doesn't explain the autopsy findings once again. B would be correct if the patient was an adult, but the patient is not an adult, the patient is a baby. The adults have polycystic kidney disease in their adulthood, obviously. But this would be autosomal dominant, right? And this is on chromosome 16. His one, chromosome 6. You guys can think of it like this. 6 is smaller than 16. So 6 is babies and recessive. And also recessive is usually small r, right? This is, right? Dominant is big. They write big R. Actually, I forgot how they write it. Whatever. Anyways, 16 is bigger than 6. Tamam, that's what matters. And usually also, why does it present in adulthood? Because the cysts in the kidney would be slow growing, right? And instead of having a billion tiny little cysts like you do in children, they would be many or a couple of large cysts. So then when did I lag? What should I repeat? Okay, so basically, the children have tiny cysts all over their kidney, right? Cystic dilation of all their collecting ducts. But the adults have a couple of cysts, but they are slow growing. And when they reach adulthood, those cysts are really large and they impact them, right? And so that's why when you palpate their kidneys, they would be really huge, sometimes like truly ginormous, that they even can palpate them. So that's basically the difference between PKD and, well, the autosomal dominant and autosomal recessive PKD, and why this child died at birth, because his entire kidney is impacted, as opposed to adults who can be asymptomatic for a large time of their life. Does this make sense? Excellent. Should we move on? Great. Okay, next question. So here we have a 45-year-old man. He's coming to you in the ER because of hematuria and bilateral flank pain. He has passed urinary stones twice before, and he has a history of recurrent urinary tract infections, and he has no recent trauma. His father has a history of kidney failure, underwent kidney transplant, and of his vitals, what's important is that he has high blood pressure. And then abdominal examination shows the palpable bilateral flank masses, or both bilateral, sorry, flank masses. Okay. Result of a complete blood count are within reference range, and his serum creatinine is 2.9 milligrams per deciliter. Which of the following findings is most likely to be associated with this patient's condition? A, why are you saying A? Like you think the stone eroded I'm not sure. What did the stone do to cause colonic wall ulcerations? Let me highlight some things for you. So he's 45, first of all, so he's an adult. He has hematuria and bilateral flank pain. Urinary stones are, okay, a good clue. And he has recurrent urinary tract infections. Father had a history of kidney failure and underwent a transplant. And look here, bilateral flank masses. Palpable bilateral flank masses. What's in the flank usually? The kidneys. And what is it? Yes, okay. B is not a very wrong answer. If you're thinking that the reflux caused hydronephrosis, for example, but it's unlikely for a 45-year-old man to have reflux. Usually, okay, you'll find this in pediatrics, but not in adults. Portal hypertension is a great guess, but actually this happens in children. And I'll explain it to you in a bit. D, osteolytic bone lesions. Are you thinking of, what are you thinking about? Like prostate cancer? Prostate cancer is osteoblastic, but malignancy makes sense. But look here, he doesn't have any symptoms that tell you that this person has cancer. For example, weight loss, right? And he doesn't look cachectic. When you talk about bone lesions, you're talking, oh, Mets, so something really advanced. So he must have symptoms of an advanced cancer, but he doesn't. Yes, polycystic kidney disease. Okay, let me explain to you. First of all, let's go step by step. This patient is, first of all, in his middle-aged, right? 45-year-old, and he has hematuria and bilateral flank pain. When I tell you a patient has hematuria, you need to have a differential in your mind. What can cause blood in the urine, right? It can be, for example, something like related to the glomerulus, but this is usually microscopic. Second, it can be a malignancy, right? It can be something wrong with the prostatal urethra, something wrong with the urethra itself, and the ureter, or something wrong with the kidney itself. And here, what really tells you that this is most likely polycystic kidney disease are a couple of things. Let me just clear this up. The first thing that tells you this is probably polycystic kidney disease is the family history. His father had a kidney transplant. Tamam? And the second thing is now he also has a problem in his kidneys. So now you're thinking this is probably something genetic, right? As opposed to like malignancies, sometimes they can be genetic, but not all the time, right? And so with the kidney, you want to think about, okay, what's something hereditary with the kidney? Why does he and his father have issues with their kidneys? The top clue here is the palpable bilateral flank masses. It's very rare for you to have palpable kidneys in a middle-aged person unless they have PKD, right? And the high blood pressure is also a clue here. Do you guys know why PKD patients have a high blood pressure? Because of the RAS system, right? The angiotensin-renin system is activated, so they get high blood pressure. Tamam? And so the hematuria, bilateral flank pain, sometimes these patients' only issue is back pain. تمام. Sometimes it's only hematuria, and sometimes they have recurrent urinary tract infection. Sometimes this patient, subhanAllah, he has a mix of everything. But this is basically how it is. And then what do these patients develop? Cerebral aneurysms. They develop issues with their mitral valves, right, in their heart. It's not low GFR, no, بس إنه يعني it just gets activated because of the cysts triggering their activation. Earlier you said portal hypertension, and I wanted to touch upon that. Portal hypertension, this is not required for you to know, but you can find it in pediatric patients who have PKD in their recessive form. This can cause issues with the ducts in their liver, much worse than adults, and then it can lead to eventually portal hypertension because of that. So it was a smart guess, but you find this in pediatrics instead of adults. I know this was pretty difficult, but again, it's about pattern recognition, right? The pattern for PKD in adults is hematuria, flank pain, okay, and it's always bilateral, and the masses. The masses, خلاص, they sell it to you. تمام. No, yes, this is definitely any, especially when it's hereditary and so on. If I tell you only unilateral, you're thinking now of malignancy. But bilateral, I'm not saying it's impossible, but it's unlikely. Does this make sense? تمام, alhamdulillah. Okay. Next, you have a 6-year-old child. He's been drinking more water with more frequent urination for the past 7 months. So he has polydipsia and polyuria. On physical examination, he's dehydrated, and the urine analysis includes pH 6.5, and okay, no protein, glucose, or ketones. So urine analysis is normal, and no white blood cells, red blood cells, or casts. And then his sodium is a little bit high. Potassium is fine, chloride, and bicarb. Now he has bilaterally small kidneys with barely visible medullary cysts concentrated at the corticomedullary junction. So you're saying B, C, or A. Okay. So the correct answer is B. What do you call this condition? This is called juvenile This is okay. And the sellout here is child, first of all. Second of all, polyuria and polydipsia. What happens to these patients is that they have little cysts at the corticomedullary junction. And this eventually leads to, and they also have interstitial nephritis. And so their kidneys atrophy. That's why they're bilaterally small kidneys. Oh, it's okay. To be honest, this lecture is very easy. And I think for the exam, juvenile nephrophthisis, I don't know if I'm saying this correctly, but this thing and PKD, both autosomal dominant and recessive, are the most important. So yani, if you're short on time, these are the high yields basically. Tamam. So why does this patient have polyuria and polydipsia? Yes, okay. MCKD1, yes, for medullary. But this patient has corticomedullary, so it's not only the medulla that's affected, right? And usually, by the way, MCKD1 is in adults. This patient is drinking more water because he is losing salt, right? His kidneys have lost the ability to conserve salt, and so he's also, yani, when you lose salt, the water goes with it. So he has frequent urination, and then now he feels like he needs to rehydrate himself, so he drinks more water. Tamam? But here you can see that he has a little bit high serum sodium, and that's not because he has a lot of sodium in his body. This is actually false. It's only because he's so dehydrated. And so the gene responsible is this one right here. PKD1 is polycystic kidney disease. Tamam? And so is this clear? Excellent. And what about this one? What's this gene for? Wait, let me erase that to make it clear. By the way, if I'm like scribbling too much, I can tone it down if it's a bit confusing. Like this is recessive polycystic kidney disease. Okay, so they added an H. But this one is dominant, and then MCKD, as you said, it's medullary. Okay, let's move on to. Okay, next question. You have a 57-year-old woman, and she has pain on urination for 5 months, and then yesterday she noted blood on her underwear. On examination, there's a tender red 1 centimeter nodule on the posterior lip of the external urethra, and then they remove it. What do you think she has? Look at her age. Her age is very relevant. Excellent. It is A. So let me ask you another question. How would you treat this patient if you don't excise it? She is a 57-year-old woman. And so 57-year-old women usually they are postmenopausal. So they have low estrogen. So if you were to give her something, what would you give her? Excellent. You would give her estrogen. The exact form of estrogen isn't pills or whatever. You would give her as an estrogen cream, and if she rubs it on this granulation tissue, it should yani, decrease in size. But in this patient, they decided, okay, let's remove the whole thing. But yes, so basically, what you call this is a caruncle. A urethral caruncle. Usually this happens in postmenopausal women because of the low estrogen. So, and they are pretty painful. Tamam? They're usually red. And since it's granulation tissue is made of blood vessels, so it bled a little bit. Well, actually, I don't know how much blood she bled, بس المهم إنه it bled. And yeah, that's it. These two you can remove, plasma cell and multinucleate cells. These are usually found in infections, and she does not have any like odor or whatnot. Rhabdomyosarcoma, this is in children, so definitely, I'm not saying definitely because it's unlikely for a 57-year-old woman. Squamous cell carcinoma would not be something that just happens in 5 months, right? She would have something before it, for example, lichen planus. And same thing for urothelial dysplasia. And also, they wouldn't be any bleeding nodules. You know, it's quite unlikely. Is this clear? Okay, amazing. You guys are doing really well, mashallah. Like, okay, here you have a 51-year-old woman with diabetic nephropathy. She received a renal allograft. An episode of acute cellular rejection requires an increase in immunosuppressive therapy. And so then she develops dysuria. On examination, she has suprapubic pain on palpation, and a urine analysis shows hematuria. And then they did a cytoscopy, and 3 to 4 centimeters soft yellow, slightly raised mucosal plaques are seen. Biopsy specimens of these lesions microscopically show mucosal infiltration by foamy macrophages with abundant pass-positive cytoplasmic granules and small laminated mineralized concretions. Which of the following organisms most likely is to be found in her urine? This is a bit of a mouthful, but chlamydia, schistosoma. Here, just notice that this patient is on immunosuppressive therapy. So her immune system is down. Excellent, it's D. So what does this patient have? What's the condition called? When you have macrophages that look like this, what do you call them? It's a fancy word. Malakoplakia, excellent. So the condition is malakoplakia, and these macrophages are called Michaelis Guttman bodies. What they're made of are basically, these are macrophages, and they have a lot of minerals inside, I think iron and calcium. And so they form these, I don't know if you can see, there you go, rings like this. And the doctor likes to call them targetoid lesions when you have a dot in the middle. Actually, it's not the doctor's pathology community, بس المهم. And usually it's either because of E. coli or Proteus. So basically the patient develops this infection. Okay, and here as you can see, she had dysuria, and she had suprapubic pain. And then after that, this is the reaction of her immune system, right? And remember, this doesn't happen in everyone. I mean, if a completely healthy person develops E. coli or Proteus infection, they might not get malakoplakia. But this 51-year-old woman has diabetic nephropathy, and she received a transplant. So transplant patients are always on immunosuppressive therapy. And the clue overall is foamy macrophages with PAS positive cytoplasmic granules. I don't think there's anything else in your lectures that has macrophages like this. So when you hear this, you think directly malakoplakia, especially since it's on cytoscopy. Is that clear? Excellent. Okay. Tamam. Next, we have an infant boy that has had recurrent urinary tract infections since birth. Ultrasound reveals dilated pelvis and calyces in the left kidney, and the right kidney is absent. Surgical repair of an obstruction is performed. Which of the following findings is most likely present at the site of obstruction? So always think of what's common. E is unlikely. B is not really something that you find in children. E gives you a different picture. We'll look at a question that is very similar to E. But this is not the picture it gives you. Also not C. See here, they said there's an obstruction, and they have a dilated pelvis and calyces. Forget about the right kidney for a second. This patient has hydronephrosis, right? So what can cause hydronephrosis in infants? When you think about hydronephrosis, you think there's fluid accumulating there, right? And what would cause fluid to accumulate? An obstruction? Exactly, it's D. Tamam. In children, okay, the most common cause of hydronephrosis is uretropelvic obstruction. So the place where the the ureter meets the pelvis is not very any well made, I guess. It prevents flow and it causes dilation and hydronephrosis, basically. The right kidney being absent is honestly, it's not really related, okay? Usually they will tell you both kidneys are dilated, but this is just how the scenario was written, I guess. Maybe the patient has some kind of syndrome. But the most important thing is that you have a tiny little boy with a dilated pelvis and callousy, and they didn't give you any other details. So when they give you very little details, they want you to think about, okay, what's common? If I tell you infant with hydronephrosis, what are you going to think about? The first thing that should pop into your mind is uretropelvic junction obstruction. تمام? For the urachal cyst, I think I have a question later on, so we'll look at that. Is this clear? This is from Dr. Uban's lecture, I believe. Always know the most commons. تمام. Let's move on. Okay, here it is. Okay. It's okay, we're learning. And also, I think the best thing you can do before the exam is to solve many questions, especially from Robbins, like when Dr. Abrar and Dr. Uban are involved. And then you solve these questions, and on a sheet of paper, you write down the topics that you got wrong. And then you go review these. You are both teaching yourself patterns and teaching yourself how scenarios come, and also reviewing your weaknesses in a very efficient way. Instead of opening all the lectures, you get to see exactly what you need to review. So you're doing great. You're doing the right thing. Okay. So now here we have a little girl, and the top of her diaper is damp. And radiological imaging shows connection between the bladder and the umbilicus. Exactly, persistent urachus. This is how they will usually give it to you, right? The urachus will give you, there will be this connection, and there will be some urine coming out of places that it shouldn't come out from, right? Usually it doesn't harm the kidney and cause hydronephrosis, basically. So excellent. Amazing. Okay, so this is a little bit of an extra thing, but what is this? What are you looking at here? It's something that happens after a persistent urachus. Adenocarcinoma, perfect. Okay, so persistent urachus and exstrophy, both can lead to villus. By the way, this is not adenocarcinoma. This is villus adenoma. Later, it can develop into adenocarcinoma. Here you can see that it's not the rule of thumb, really. If it's cancer, it's going to be ugly. So here it's not that ugly, it's an adenoma. You can see very roughly, okay, it's not very clear at all here, but yani the cells are just huge, right? And they have they're not really touching each other that much, but they're not neat like they usually are, right? And so exstrophy and persistent urachus can lead to villus adenoma, which can eventually become adenocarcinoma. The one here that cannot become, or it's unlikely for it to become a villus adenoma and then an adenocarcinoma, is the diverticulum. And speaking of a diverticulum, how does it look like in children? Or in other words, when you have a diverticulum, you can either have it in children or adults. What's the difference between the two? What's something that you find congenitally that you don't find in adults? Exactly. So the muscularis layer would be included in the diverticulum when it's congenital. But if it's acquired, it would just be the lamina propria and the mucosa. Perfect. Okay. Next question. You have a 29-year-old man complaining of a vague feeling. Okay, this one. Okay. A vague feeling of painless heaviness in the scrotum for the past 5 months. He is otherwise healthy. Physical examination shows that the right testis is slightly larger than the left testis. And an ultrasound scan shows a solid, circumscribed 1.5 centimeter mass in the body of the right testis. The representative gross appearance of the mass is shown. I guess I didn't put it. Okay. Okay, fine. But I'll tell you, it looks pale, yellowish, okay, and not a lot of hemorrhage. So a biopsy is done, a microscopic examination shows uniform cells with distinct cell borders, glycogen-rich cytoplasm, and round nuclei with prominent nucleoli, and there are aggregates of lymphocytes in between these nests. Excellent. This is a seminoma. So which of these would you choose? Excellent. C. Of all tumors in the testis, this is the only one that responds well to radiation therapy, which is a really good thing. And so I should have put this before actually, but there you go. So it's tan yellowish with minor little hemorrhage, not a lot, right? And so what tells you this is a seminoma is first of all, it's circumscribed. Second of all, the cells are uniform, and they're the only ones that have rich cytoplasm like this. They're round and they actually look pretty okay with aggregates of lymphocytes. Tamam? So you guys are correct. Let me ask you this then. What causes elevation of HCG? Which of the tumors? And the HCG is found in pregnant ladies usually. Yes, so choriocarcinoma, not embryonal, choriocarcinoma. Embryonal is actually, it doesn't have tumor marker. When it's a pure, like embryonal carcinoma, no tumor marker. But the one that has HCG 100% is choriocarcinoma. Chorio, so cytotrophoblasts and syncytiotrophoblasts. These are the cells that basically work on attaching the embryo to the mother, and they are the ones that secrete HCG. And so if they turn into a cancerous thing in males, they will also secrete HCG. How about alpha fetoprotein? Which of the testicular tumors has elevated alpha fetoprotein? So I'll give you the options: seminoma, embryonal carcinoma, yolk sac tumor, choriocarcinoma. Let's also say teratoma. Yolk sac, excellent. So the yolk sac has alpha fetoprotein. Choriocarcinoma has HCG. Now I'm gonna trip you up a little bit. Okay, later I'll trip you up a little bit. Not now. Like, okay, we'll get back to the testicular tumors in a bit, I think. Like, now you have a 23-year-old. Wait, is this clear? Okay, perfect. By the way, these two, just FYI, this one is Fragile X syndrome, and this one is Klinefelter. Fragile X syndrome can have slightly enlarged testes, but they would be bilateral, and they would give you some retardation. Klinefelter actually has shrink testes. Sometimes, I think sometimes they're even absent. Okay. Okay, so you have a 23-year-old previously healthy man, and he's suddenly developed severe pain in the scrotum. The pain continues unabated for 6 hours, and then he goes to the ER, and then on examination he is febrile. He is afebrile, sorry, and there is exquisite tenderness of a slightly enlarged right testis. Excellent, you guys are correct. So this is the gross appearance, and as you said, the answer is D. Tamam. What happened to this? Exactly, torsion. So usually it happens to children and even happens to young people. They literally be asleep and then they wake up with this severe pain. The keyword for you is suddenly and severe pain in the scrotum, and it's continuous. It doesn't come and go. It keeps going. Tamam. And if you okay, let me ask you. If I lift the scrotum, what will happen to the patient? Will it relieve his pain? Will it keep going? No, no, it will. I think it will relieve it. This is called the cremasteric reflex. I think. Is it called the cremasteric reflex? Let's just make sure of it in a minute, because I believe that when you lift the scrotum, it does relieve the pain. But anyway, moving on, as you said, there is obstruction of the blood flow. Prince sign. Okay. Negative. So the pain is not relieved. Oh yes, it's relieved with epididymitis. Thank you so much. So with epididymitis, which is basically inflammation of the epididymis, you do get relief. But with testicular torsion, you don't get relief, which actually makes sense because, as you said, there is obstruction of the blood flow. So what's going to relieve that except surgically maneuvering so that the flow is restored? And yeah, I think this is it. Is this clear? Thank you, Malak. Okay. Next question. So we have a 28-year-old man, and he has noticed increasing enlargement and a feeling of heaviness in his scrotum for the past year. On physical examination, his right testis is twice its normal size, and it's firm and slightly tender. The ultrasound shows a 3.5 centimeter solid right testicular mass, and abdominal CT shows enlargement of the para-aortic lymph nodes with multiple lung nodules on chest radiograph. So he has metastasis. This is most likely cancer, okay? طيب, I shouldn't have said that. طيب, laboratory findings include increasing levels of chorionic gonadotropin and alpha-fetoprotein. Which of the following neoplasms is the most likely diagnosis? So here, there's a keyword that points you to the answer exactly. Like, should we show the answer? Okay. So as you said, the answer is E. And the clue here, the only clue honestly, is that both chorionic gonadotropin and alpha-fetoprotein were elevated. تمام. In choriocarcinoma, it's only HCG. And in yolk sac tumor, it is only alpha-fetoprotein. And then the rest, they have different kinds of markers. Any Leydig cell tumor, which is a sex stromal cell tumor, wouldn't give you these findings of chorionic gonadotropin and alpha-fetoprotein. The one exactly testosterone. So here, this is from your lecture, but I just wanted to show you here that, as you can see here, 90% of patients have both elevated. تمام? Choriocarcinoma, HCG. In yolk sac, AFP. I wanted to bring questions on the Leydig cell tumor, but it was not ever in the past, and the doctor did not give you any slides on it, so I decided not to give you any. But usually they would show you a picture of a male with the testicular mass and gynecomastia. Usually this is the picture that comes. But I highly doubt he'll give you anything. I don't think he gave us anything in our exam, and there was nothing in the slides. So I stuck to what was in the slides. تمام. And then another thing I want you to take from this are the ages. تمام. For example, you won't find a yolk sac tumor in an adult, you'll find it in a small child. تمام. Pediatrics. Meanwhile, a seminoma is usually not something you'd find in pediatrics because it usually comes in middle ages. تمام. And so these ages part and the tumor markers are the most important thing. And of all of these morphological features, I think this one would probably be the most important, followed by a choriocarcinoma with the, or the yolk sac tumor with the Schiller-Duval bodies. تمام? So in your review, make sure you go through all of these and you make sure you look at what Schiller-Duval bodies look like, and the gross finding of a seminoma. تمام. Let's move on. So it's currently 8. Do you want to take a break or do you want to keep going? We're on slide 39 right now. I think there's a total of 53. Come on, let's keep going. So a 55-year-old man comes to your office due to progressive urinary frequency, urgency, and hesitancy for the past several months. The patient also reports new onset low back pain and perineal pain during ejaculation. He has no dysuria, no hematuria, and he is a smoker, packs cigarettes daily for 30 years. Temperature is normal, blood pressure is 130/76, and pulse is 80. There's no suprapubic or costovertebral angle tenderness. External genitalia examination is normal. Rectal examination has increased anal sphincter tone and a smooth, slightly enlarged prostate. Deep tendon reflexes are normal, and urine analysis, the only thing it shows you is many leukocytes, and culture is negative. PSA is 2. The normal is usually less than 3.5. So what's going on with this patient? So he's 55, and he's giving you all of these urinary symptoms. Wait, let me remove that. Okay, all of these urinary symptoms, and culture negative, hyperplasia. It's not hyperplasia, but I can see why you would say that. It is a smart guess. But first of all, look at the PSA. Secondly, look at the timing. So this is something that developed over a few months. Excellent. D. So this patient has chronic pelvic pain syndrome or non-infectious chronic prostate inflammation or prostatitis. And usually what this has is symptoms very, very similar to BPH. تمام. But also the other thing that BPH doesn't have back pain. Usually, at least in the scenarios that I've seen, all about any chronic pelvic pain syndrome, they all have back pain and perianal pain or perineal pain. The BPH usually doesn't have back pain, tamam? And the second thing that points you to this most likely not being BPH is that it developed over the past 5 years, but this one several months, and he already has frequency and urgency and hesitancy, tamam? And then other features of chronic pelvic pain syndrome is that it's non-infectious. تمام? So they do have many leukocytes, but the culture grows no organisms. And even sometimes they'll tell you that the prostate size is normal. In this scenario, it's slightly enlarged. Does this make sense? So if you were to pick up a pattern for chronic pelvic pain syndrome, BPH symptoms that developed in a shorter time span than it usually does, PSA is normal, culture is negative, and they'll usually tell you that. They'll usually emphasize it. As you can see here, for example, they told you, there's no dysuria, there's no hematuria, so you kind of rule out, for example, malignancies and stuff. His temperature is normal, right? Culture, negative. So most likely, this is something that is non-infectious and most likely any chronic pelvic pain syndrome. Okay. Now we have a slightly older patient, a 78-year-old man with increasing difficulties with urination. See, it's getting worse. For the past 6 years, he has difficulty starting and stopping the stream, and on physical examination, temperature is normal, blood pressure is 130/85, and this is his bladder. What would you find in this patient? Excellent. C. So his PSA would be slightly high. And just for your information, you don't need to, I wouldn't say this is very important for the exam. It won't determine anything for you, but PSA of more than normal. مثلا 4, 5, but less than 10, this is most likely BPH. If it's more than 10, then this is most likely cancer. تمام? Now, I want you guys to tell me the 2 findings that you can see on this picture. Stone, perfect. And one more thing. Trabeculations, excellent. So the trabeculations developed because he's straining really hard to empty his bladder. So those muscles decided, okay, if we're going to strain ourselves so much, we might as well grow some more muscle. So they have these trabeculations. And the stone is there because despite his best efforts and his bladder's best effort, he's still, look at how enlarged this prostate is. It's really huge. But despite his best efforts, he's unable to fully empty his urine out of his bladder. And so this urine, it has all sorts of things, including minerals. So it calcifies and it turns into a stone. تمام? I think this is pretty straightforward. Okay, let's move on. So, same scenario. What do you think is the condition he's at most risk for? same patient. Excellent. Hydronephrosis. So we saw that this patient has increasing difficulty in emptying his bladder. So he has urine left over there, and the urine is always coming from the kidney. So if it's unable and also because he has trabeculations for the uretropelvic junction or the retrovesical, sorry, junction might have some angulation issues, and so the urine will go back to his kidneys and it will fill up, and cause hydronephrosis. Prostatic adenocarcinoma is highly unlikely in BPH. Usually it doesn't it doesn't lead to it, so we're not really worried about it. Excellent. Yeah. Okay. Next scenario. A 67-year-old male presents to his family physician, whom he has not seen in several years, with complaints of back pain and left thigh pain. Other than mild hypertension controlled with a beta blocker, he has no other significant past medical history, and his vital signs are a temperature of 98.9 degrees Fahrenheit, pulse of 81 beats per minute, and his blood pressure is 127/71 millimeters mercury. This is all not really important. ALT, AST normal, GGT normal. Alkaline phosphatase is 223, and TSH is 1. Okay, PSA is 53. Okay, what do you think this patient has? As you said, B. So he has, okay, you said C, which is, okay, so let's dissect this. First of all, we can all agree that this patient has a metastatic disease because, well, that's what the scenario says, but also well, honestly, they didn't mention prostate issues, but okay. Um, so what happened to this patient most likely is that he had prostate cancer and then it metastasized to his bone. And actually, sometimes it doesn't have any symptoms because which zone of the prostate does it usually happen at? Why doesn't it? Exactly, peripheral. And they gave you liver enzymes and alkaline phosphatase just so that you can do a correlation because alkaline phosphatase can be elevated in many conditions. But if I tell you alkaline phosphatase and PSA, now you're thinking, okay, most likely prostate cancer. Prostate cancer can metastasize in either lymphatically or hematogenously. Here he has an osteoblastic mets. Is it hematogenous or lymphatic? Hematogenous, perfect. So if it metastasizes hematogenously, first place it likes to go to is the osteoblastic mets, or the spine, and that's because of the plexus. What was it called? Bates plexus. I'm not sure honestly what it was called, but it started with a B. And basically, there's a plexus of veins. There's your prostate, and then there's a plexus of veins it's connected to, and there are no valves, so it goes directly up when it wants to drain to the spine, and so that's why it goes directly to the spine in you when it wants to metastasize through blood. And usually they are osteoblastic, not osteolytic. And that's why you see alkaline phosphatase being high. It wouldn't be high if it was osteolytic, right? When you're osteoblastic, you're building bone. And so I don't have the picture right now, but in your lecture, you'll find that there are like sort of, I don't know, lumps on the spine. It's basically a bumpy spine, right? Is that clear? If this, once we finish with this, we can go to your lecture. I can open it and show you the spine. Excellent. Okay. So we have a 60-year-old man coming to the physician because of a 1-week history of low back pain. He has several episodes of painless hematuria for the past 2 months, and physical examination shows localized tenderness over the lumbar spine. CT shows multiple osteolytic lesions in the body of the lumbar vertebrae, and the cytoscopy shows a 4-centimeter mass in the lateral wall of the bladder. And this is the biopsy. So what's causing this patient? What's the risk factor of this patient's condition? B and D. Okay. So let me get, yeah, first of all, what does this patient have? What's the condition that the patient has? He did the cytoscopy and there's a mass in the lateral wall of the bladder, so he has cancer, right? No, it's a great guess. But but look here. If he has cancer, what kind of cancer do you think he has according to the biopsy? Adenocarcinoma. Perfect. So, that makes the answer B correct. Cigarette smoking is a big risk factor for adenocarcinoma of the bladder. Like you said schistosoma infection, which is a great guess, but schistosoma doesn't cause adenocarcinoma. It causes squamous cell carcinoma. So instead of seeing this, you would see keratin pearls, right? And squamous cells. But look at these cells, they resemble adenomatous cells more than they resemble squamous cells, right? Exactly. So this is why it's unlikely to be schistosoma. And also, for some reason, the questions that I found about schistosoma all like to mention the patient went to Africa. So if you find that in your exam, you can be suspicious of schistosoma infection. Alcohol consumption, usually esophageal cancer, it doesn't really have to do with the bladder. Chlornicus is a liver fluke, so that's unrelated to the bladder once again. Vinyl chloride, I believe that's for the lung, and nitrosamine, that's gastric cancer. So these are all, carcinogens, but the one that causes adenocarcinoma in the bladder is mostly cigarette smoking. Okay, is that good? Excellent. We're almost done. Okay, like a 72-year-old man comes to the physician because of several episodes of dark urine over the past 2 months. He has had a 6 kilogram weight loss over the past 3 months, despite no changes in appetite, and he smoked a pack of cigarettes daily for 30 days. CT shows a heterogeneous enhancing mass arising from the left renal pelvis. So, which of these do you think would be the pathological finding in this patient? It's okay. Even if you haven't studied, okay, this particular lecture, look here. So they're saying, this patient clearly has cancer. We can agree on that because he has weight loss that is with no changes in appetite and he's a smoker. So this tells you this is most likely a cancer. They did the CT and the mass is from the renal pelvis. Okay, now they're asking you what kind of cells are in there. So, so let me ask you, what kind of cells usually sit in the renal pelvis? What are they made of? We know we have a kidney with lobes, and then we have nephrons and glomeruli, and then we have pelvis, and it comes out and forms ureters, right? So this part here, what are the cells made of here? They're not muscles, but the ureter does have muscle around it. But you have, let me give you the options. For example, adenomatous cells, or yeah, pretty sure they have a different name. Okay, squamous cells, urothelial cells, nephrons, ducts and tubules. No, not tubules. The tubules are in the kidney. So the cells that you have in the pelvis are urothelial cells or transitional, right? And so they're basically the same epithelium as the ureter and as the bladder, right? They're called urothelial cells. I wish I had a picture. Okay, but anyway, that's what they're made of. And so here you can clearly see the one with the urothelial cells is A. Tamam. And so this is a bit of a tricky question because we're saying that there's a renal cancer, but what kind of renal cancer? They're telling you it's from the renal pelvis. So you rule out renal cell carcinoma, right? And so one squamous cells, it's unlikely for a squamous cell carcinoma to happen here. So you can say, it's unlikely. It's not my first choice. Tumor with central scar. Which one is the tumor that has a central scar? It is in your lecture. It's the oncocytoma. And the oncocytoma, the two main things you want to know from that is that it has a central scar and the issue is with the mitochondria. Tamam? That's what you need to know about oncocytoma. So when I tell you central scar, this is not transitional cell, this is not renal cell carcinoma, this is oncocytoma. Tamam? And then it usually doesn't happen in any demographic, basically. The polygonal cells with lipids and glycogen, what is this one? So when they tell you that they are polygonal cells with lipids and glycogen, it's basically another word for this is clear cells. Not adenocarcinoma. This also arises in the kidney. This is renal cell carcinoma. تمام? So renal cell, clear cell. تمام? Renal cell carcinoma, clear cell carcinoma. You can kind of, I don't know. I don't have a very good mnemonic right now. But anyway, these are basically renal cell carcinoma. This is oncocytoma. This one is unlikely. It's squamous cell. And the last one, primitive blast stem cells and whatever thing you took. At the end of the day, what I want you to take from this is renal pelvis is made of urothelial cells, and urothelial cells give you transitional cell carcinoma, or urothelial cell carcinoma. It can arise in the kidney. Where in the kidney? The pelvis. So can it arise? Hey, we're sorry about that. Like, I think we're done with this one. What were we saying? Yeah. So the urothelial cell carcinoma, all you need to know, or from this question, you need the objective, is that it does arise from the kidney, the switch part, the one that has urothelial cells, which is the pelvis. Come on. So is this clear? Let me pull up the chat. Is this question clear to you guys? Great, alhamdulillah. Like, you're almost done. Like, last question. This time, you have a 69-year-old man, and he's coming to you because of a 1-week history of blood in the urine and fatigue. He also has had a 5-kilogram weight loss during the past month. Physical examination shows pallor and cachexia, and non-tender right flank mass is palpated. only in the right. Okay, CT of the chest and abdomen and pelvis shows a 5 centimeter right upper pole renal mass and several pulmonary lesions. And then a biopsy is shown. So this biopsy here, what do you think you can see? Of all, it's one of the things that we talked about earlier. Okay, should we show the answer? Okay, so as you said, the answer is C, VHL gene mutation, and yes, it is renal cell carcinoma. So this is what the clear cells we were talking about look like. And there's something that Dr. Uban referred to as chicken feet, which is the look of blood cell. I guess you can consider this one chicken feet, two chicken feet. Okay, so it's like chicken feet stepped on these cells. But anyway, regardless of the chicken feet, you can see, oops, you can see that you have clear cells, right? Um, with abundant lipids in them. And we said here right upper pole. So I'm showing you this because first of all, the gross examination of the renal cell carcinoma seems relevant to your exam. It's usually yellow and tan like this. And I don't know, I've noticed that most of them happen in the upper pole, but they can also happen in the lower pole, of course. Now NF1 gene, this is neurofibromatosis. PKD1, what is this one? Polycystic kidney disease. Dominant, excellent. This one is lung cancer, it's irrelevant. TSC tuberculin, where do you find this? This one, it could have been one of your options here, if not for the biopsy and maybe the weight loss. This one gives you some kind of pathology in the kidney, and it's usually benign, but it doesn't really behave like something benign. So this one gives you angiomyolipoma, right? And so it would show you a very similar picture here, but instead of only cells filled with lipid, it would also show you lots of blood vessels and muscle. And it would also come with the other symptoms like epilepsy, for example, which this patient doesn't have. Finally, this one is Wilms tumor, which happens in kids. So bye-bye to this one. Tamam? Is this clear? And guess what? You are done. So of course I mean, I couldn't put all pathology questions ever in this session, but please solve Robbins. It will help you a lot for the exam. And it contains a lot of high yields and solve past questions because some of the concepts that are included in the slides are not in questions any by other resources. Like for example, cystitis glandularis or cystitis cystica, I think it's called, some abnormalities of the ureter. I tried my best to look for questions for these, but I couldn't really find many. So make sure you solve the past questions, but also make sure that you solve Robbins in particular. And solving questions will really help you. You might think, okay, this is a common thing. You might think, oh, I didn't study this, so I can't solve questions on it. No, solve questions on it because that is what will come in the exam, and that is what you will learn from. And then when you solve questions, you get some wrong, you get some right. The things that are wrong are basically your weaknesses, right? So this tells you, okay, this is what I need to review. Instead of reviewing the whole lecture, I review only my weaknesses. Um, and yeah, if you have any questions, any concerns, anything at all that you want, please, yani, contact me. Um, Available all the time. This is my number, this is my email. And please scan this code because uh anytime من جد الله يوفقكم يا رب ويفتح عليكم فتوح العارفين and this exam إن شاء الله will be easy. Um, and it's the first exam of the semester, so yeah, you got this إن شاء الله. This is a really fun block, right? this is المهم. الله يعافيكم يا رب. Again, if you have any questions, any concerns, even unrelated to this, here's my number and my email. And please scan this code so that, because feedback is the most important thing basically. و الله يوفقكم يا رب يفتح عليكم.